Testing, diagnosis and prognosis. So the objectives of the talk will be divided into 4 parts. We'll explain the different components of CPET report, which is really important to understand the interpretation for the CPET, and then we'll describe the methods for interpreting results. And to
محمد
know
ممكن ترفع الصوت بس زيادة شوي، تقرب الميكروفون شوي. جميل. Go ahead.
طيب كده ممتاز، الصوت كده ممتاز.
جميل. نعم.
طيب so and then we'll identify factors that influence our interpretation, which is really important to know these factors, and then discuss the clinical implication of the findings of CPET report. So CPET, usually we know that we are focusing about the peak of oxygen uptake, VO2, which is really very important parameters in CPET, but this is not the only information or parameters or important parameters in CPET. We have many things in CPET that we can extract from the curve and from the numbers. So also the importance of CPET to identify factors that contributing to dyspnea and exercise limitation. So we can know the pattern. Is it the cardiac or pulmonary or ventilatory limitation? Also, it helps to evaluate the impact of therapeutic intervention for our patient, either surgical intervention or medical treatment. And to assist if the patient planning for exercise training, it's really important for the athlete and our patient also. And it's really important tools to generate prognostic information and to screen for coexisting ischemic heart disease, peripheral artery disease, or arterial hypoxemia in our patient. So Fick equation is really very important equations in CPET that can help us to understand the VO2, important of VO2 parameters, which is equal to cardiac output times the oxygen content. And as you know, the cardiac output is the stroke volume times heart rate. So from these equations, we can understand the parameters of or the interpretation of VO2 and the implication of VO2. So if we can make the cardiac output heart rate times stroke volume, so if the patient has, for example, chronic incompetence, the VO2 will be low. Or the patient in drug-induced beta blockers, for example, so the VO2 will be low. In the patient with cardiomyopathy or low ejection fraction, stroke volume will be reduced, and then the VO2 also will be reduced. The other important factors that can decrease the level of VO2, the level of anemia. So if the patient has anemia or oxygen saturation is low, that also will reduce the level of VO2. Also, if the patient has myopathy, disease in the muscles or neuromuscular disease, also that will affect the level of VO2. So it's really important to know why a patient has low VO2 and why where it's coming from the reducing level of VO2. So the factor that's affecting the interpretation of CPET, starting by the patient related, So it's vary with the age, gender, and fitness level, and the baseline of the condition, obesity or anemia. The second factors that test related, so the protocol selection, treadmill versus cycle ergometer, and the calibration equipment reliability, also that affect our interpretation. And then we'll come to our identify pattern, physiological pattern, starting by cardiovascular, and then pulmonary or musculoskeletal. So the rationale of CPET to meet the metabolic demand of exercise, that the body need to increase effectively ventilation and increase cardiac output and decrease the pulmonary and systemic vascular resistance and increase the oxygen extraction from the cells. And then we can identify the etiology of exertional dyspnea. And we can divide it into three parts, either impaired external respiration or impaired circulation or impaired internal respiration peripherally, capillary gas exchange or oxygen utilization. And cardiorespiratory fitness, it's shown in many studies that can predict morbidity and mortality, and we'll talk about this at the second part of the lectures. So the component of the CPET report, we can summarize it into 7 points. The first point, the baseline data, resting heart rate and the blood pressure and pulmonary function test. All the patients, they are doing the CPET, we need to do spirometry before the test to know the baseline of spirometry and to measure the forced expiratory volume in first, second, and FVC. And then we have the metabolic parameters, oxygen uptake and carbon dioxide output, and respiratory exchange ratio, and to determine the anaerobic threshold. We'll talk about these parameters in the lectures. And then we have cardiovascular parameters. So we'll see the response of the heart rate and the blood pressure response during exercise. We'll look for the ECG abnormality in the test and oxygen pulse. In the respiratory, we look for the minute ventilation, tidal volume, and breathe reserve, and tidal O2 and tidal CO2. And at the level of the pulmonary gas exchange, we look for the saturation level and the slope, minute ventilation to CO2 slope or minute ventilation to VO2 slope. Also, the 6 points in the CPET report, we look for the exercise capacity. So we look for the peak of VO2 and workload. And then we have the subjective data, the symptoms of the patient, why the patient stopped the exercise. Is it due to dyspnea or chest pain or leg fatigue? And it's really important to know this because can help us to identify the pattern of the patient. So the normal cardiopulmonary response to exercise it's summarized in this table. So the VO2 usually will increase with exercise up to 12 to 18 times. Heart rate, as you know, heart rate will be double or triple the level of the resting heart rate normally. Stroke volume will increase up to 1.5 to 2. Cardiac output will increase 4 to 5 times at the peak of exercise. And the minute ventilation will increase 20 to 25 times at the peak of exercise. So it's really important to know this parameters so we can identify the pattern of the patient based on this level. Is it abnormal or normal? So before interpreting the CPET, we need to know what is the normal and what is the abnormal level of these parameters. Also, the other parameters that we can expect normal level of VO2 should be more than VO2 85% of predicted. And the slope, this is very important parameters in the CPET. So the slope normally should be less than 35, slope of minute ventilation to VCO2. It's very important parameters to in prognosis and to determine the anaerobic threshold. We'll talk about this in the coming slide. Oxygen pulse normally should be more than 80%, and by the absolute number normally should be more than 10 in women and more than 15 in male patient. Tidal CO2 normally between 36 to 42, and heart rate recovery normally should decrease less than 15 beat per minute in the recovery. Exercise time normally should be between 8 to 12 minutes. So we have this respiratory exchange ratio. It's a ratio between the VCO2 to the VO2 that can indicate the maximum effort of the test. That patient, we ensure the patient has the maximum effort of the test. So if it is more than 1.1, that reaching the maximum effort of the patient. But if decreasing, that means we didn't reach the maximum effort. Also the heart rate, other parameters that we can validate our tests regarding the reaching the patient to the maximum level of the exercise. This parameters is very common and important parameters, and we know about it all. It's the peak VO2, oxygen uptake. It reflects the aerobic capacity, and it's a maximum amount of the oxygen consuming at the peak exercise, and it's indicate the of cardiorespiratory fitness. As we discussed before, it's equal to cardiac output times oxygen content, and normally should be more than 80% of predicted. And if it's reduced, that means it's abnormal. We have abnormal CPET, but we need to identify the better by the other parameters. So as shown in this curve, we have what we call 9 panel plots in the CPET reports. We're looking for the curve. One of the most important curve, that's peak VO2. So normally should be peak and plateau at the peak of exercise. And we look, as you can see here in this orange dot, this is the peak of VO2. So we can identify the numbers of the peak, and is it early plateau or normally plateau, and what's the level of the VO2 at the maximum of exercise. And in the x-axis, we can look to the based on the time, or based on the speed, or based on the grade of the cycle ergometer. This is also very important prognostic parameters. We should look at it at the CPET report in the peak of exercise, the peak of VO2. So the definition of the exercise oscillatory ventilation, it's the breathing pattern during the exercise, and it reflects the circulatory delay and low cardiac output relatively to the metabolic demand. This is typically seen in heart failure patients with impaired cardiac output and pulmonary congestion, and it causes fluctuation. As you can see here in the B paragraph, there is fluctuation of the curve during the exercise, and it's defined should be more than 60% of the progression have fluctuation, 60% of this, and should be the amplitude more than 15%. So if we have 60% of fluctuation during the peak of VO2 and the amplitude 15%, That means we have abnormal exercise voluntary ventilation, and its prognostic significant associated with 3 times increased mortality in heart failure patient. So as you know all, the tidal volume, just to remind you about this definition, because it's really important to understand it in context of the CPET report. So the tidal volume, it's the amount of air exhaled or inhaled in single breath. And the definition of the dead space is tidal volume changed between 30 to 35 at rest, and 50 to 15% at the peak of exercise. So normally our dead space should be reduced. This is a normal patient. And we have what we call minute ventilation, VE. The definition of the minute ventilation, it's the volume of air moved in and out of the lung per minute. During the CPET, the patient breathes through the mouthpiece connected to the metabolic cart, and the machine records the amount of air inhaled and exhaled in liters per minute. So we can look for why it's important minute ventilation, because it's equal to tidal volume times respiratory rate. So from this we can interpret our findings. So normally at the instance of exercise, the minute ventilation will increase by tidal volume. And then at the higher exercise, the minute ventilation will increase by both tidal volume and the respiratory rate. So the other important information, so what we call maximum voluntary ventilation. So defined as the largest volume of air that can be moved in and out of the lung during a short period, 10 to 15 seconds. So we have two methods to have the identify the maximum voluntary for our patient, either to get it from the FEV1 from spirometry times 40, or to ask the patient to breathe forcefully in 10 to 15 seconds, then we record the maximum voluntary ventilation. So from the maximum voluntary ventilation and minute ventilation, we have important parameters, what we call it peak of minute ventilation, ratio of the peak minute ventilation to the maximum voluntary ventilation. And this measure the ventilatory reserve. Normally should be the ratio between 60 to 70. So if the ratio is more than 80%, that indicates pulmonary or ventilatory limitation. On the other hand, if it's normally between the normal level or less than 60, that suggests non-pulmonary limitation, cardiac or deconditioning, or the other limitation. So it's really important parameters that we can help us to determine the pulmonary limitation. Also, we have this carbon dioxide output. It's the amount of CO2 exhaled by lung per minute, and it's measured by the CPET by the mouthpiece. So they can measure the concentration of carbon dioxide, and it will be calculated in the tables. And then we have this really very important parameters in CPET, what we call it anaerobic threshold. So this anaerobic threshold, it's the point where the lactate accumulation begins with exercise. So it's so at the onset of exercise, the patient will be dependent on the aerobic metabolism. Then at the peak of exercise, the aerobic metabolism will be changed to anaerobic metabolism. So to identify the point that the patient start to accumulate lactate, it's really important parameters to know the better and to know the prognosis, and I will show you in the other slide how is it this parameters help us to prognostic our patient. So anaerobic threshold normally should be more than 40%. So if it is low, less than 40%, that reflects either impaired oxygen delivery or utilization. But we cannot localize the organ system responsible for this low level. And we have several methods to determine the anaerobic threshold level. For example, as shown in this curve, it's just put all the curves at the one bar graph. So when the patient start to increase minute ventilation steep, that means this is the level of anaerobic threshold start to have. Also in the, we can identify it by the curve of VCO2 and VO2. If the VCO2 increased rapidly, also that means this is the level of anaerobic threshold. Also, we can identify it by ventilatory to VO2 equivalent ratio and ventilatory to VCO2 equivalent. So if the ventilatory VO2 increase and the ventilatory to VCO2 decrease, that means the level is here, of anaerobic threshold. So from several methods, we can know, not exactly, but roughly what is the anaerobic threshold by this curve, look into the curve and progressive of the curve of many parameters. Usually we didn't depend on one parameters, but we look for many parameters to identify the anaerobic threshold. Also in the CPET report, we have what we call minute ventilation to VCO2 slope. It reflects the efficiency of ventilation. So during the CPET, minute ventilation, the VCO2 are measured continuously as the patient exercises. So we can follow this curve. So if the slope is elevated, we identified by more than 34, it's considered as hallmark of condition of like heart failure or pulmonary vascular disease, and considered as abnormal due to increased dead space or and ventilation perfusion. So for example, in heart failure patient, often causes pulmonary congestion and impaired blood flow due to lung hypoperfusion and elevating filling pressure, which create a ventilation perfusion mismatch. So that area with poor blood flow, low perfusion, cannot efficiently exchange CO2, and that lead to increased dead space ventilation and reduce efficiency of the CO2 elimination, and then can lead to hyperventilation, where ventilation exceeds the amount of CO2 produced, and then BCO2 levels drop due to excessive ventilation. So as shown in this curve, so normally we should have the slope curve less than 34. In the extreme level, like 63 VCO slope, this is very suggestive for severe pulmonary artery hypertension. If we have these numbers, that means maybe patient very likely to have pulmonary artery hypertension. Also, this is another important parameters in CPET, what we call it oxygen pulse, defined as oxygen pulse, oxygen uptake per heartbeat, and serving as a rough surrogate for stroke volume. Normally should increase at the start of the exercise as stroke volume rises to meet metabolic demand, and then plateau at higher exercise intensity when stroke volume stabilize. Normally should be more than 80%, and as we mentioned before, in female should be more than 10, and in male should be more than 15. And we have to know that the oxygen pulse might vary with the age. So older patient wouldn't expect to have those numbers. So we should consider that in our report. So if it's impaired, what we mean impaired, that the oxygen pulse blunted or early plateau that reflect reduced stroke volume or limited cardiac output, which is commonly seen in heart failure patients. Oxygen uptake efficiency slope, another important parameters defined as the relationship between oxygen uptake and the logarithm of ventilation during exercise, and it reflects the efficiency of oxygen uptake across all exercise intensity. The advantage of this parameters, it's considered as highly reproducible and less influenced by effort. So if the patient didn't reach the maximum exercise efforts, we can use these parameters to have important information about the prognosis, and we'll discuss that in the coming slide. So the clinical implication from the CPET report, after we review most important, I cannot discuss all the parameters in the CPET, but I will just give you some important parameters, or most important parameters that commonly seen in the CPET report. So we can, at the end of the report, we can have 4 categories, either normal CPET, so that suggests there is non-organic causes, maybe an anxiety, or cardiac limitation. And usually cardiac limitation will have, of course, reduced VO2 and early anaerobic threshold and low oxygen pulse. Pulmonary limitation will have also reduced peak VO2 and increased slope of V to VCO2, and low oxygen saturation and increased ratio of minute ventilation to the maximum voluntary ventilation. The fourth better, what we call deconditioning, that patient will have reduced peak VO2 and workload, but normally ventilatory and cardiac parameters. So in the interpretation of the results, we should have the steps just to have systemic approach for reading the CPET reports. So first of all, we should make sure there is no technical errors, and we'll discuss that in the coming slide, and to see if the patient reached the maximum efforts, looking by the respiratory exchange ratio should be more than 1.05, and also looking for the heart rate predicted. If not reached this level, we can use the submaximal test parameters, and we'll discuss that in the coming slide. And then step 2, to look for the peak VO2. Is it normal or abnormal? So the abnormal it will be less than 80%. And if it's normal, consider non-organic causes. But if it's abnormal, we cannot identify the pattern. We need to look for the other parameters. Then we look for the ventilatory reserve. Is it abnormal or not? And this can help us to differentiate between the pulmonary limitation versus non-pulmonary limitation. And then we look for the anaerobic threshold, and is it normal or abnormal? Abnormal, it will be less than 40%. So the pulmonary limitation, usually patient will have a high ratio of minute ventilation to the maximum voluntary ventilation, more than 80%. If it is low, that means we should look for the other pattern to confirm it by the other parameters. Also, the other parameters can help us to identify the pattern of pulmonary limitation, to look for the breathing reserve. So to look for the tidal volume and respiratory rate. If the tidal volume plateau early, that suggests restrictive or obstructive lung pathology. Also, if the high respiratory rate at low tidal volume, that indicate inefficient ventilation. This table, just to summarize the pattern of the limitation. So as you can see here, in COPD patient will have high ratio and early anaerobic threshold plateau, and the respiratory pattern typically it will be high and shallow, and of course the slope will be increased. In the opposite, heart failure patient will have late or absent tidal volume and increased slope. And the pulmonary hypertension will have very increased slope in the minute ventilation to VCO2. I will show you the other tables that also can help us to understand the CPET report. So the additional CPET data to support ventilatory limitation, to look for the oxygen saturation. So if the patient desatting during exercise, that can help us to identify the pulmonary or ventilatory limitation. Also to look for the peak VO2 and tidal CO2 pressure. So usually in pulmonary limitation, they will have low PIT CO2 and during exercise, and that indicates pulmonary disease. So as shown here, in this diagram, we'll start looking by the CPET to the peak VO2. So if it is abnormal, we look for the other parameters. But if it is at normal peak VO2, that's reassuring us that patient likely doesn't have severe or moderate severe disease, either to have normal or mild disease or obesity or anxiety. But if it is low, we should try to identify the better. So many methods that or steps we can go through it, but just to have a special way for everyone. So as shown in this paragraph, they are looking for the anaerobic threshold, then to differentiate between normal or abnormal. If it's low, they will look for the breathing reserve. If it is low, that means it's mixed etiology, but if the breathing reserve is normal, that's confirms circulatory impairment. Also, in the other hand, if the anaerobic threshold normal, they are looking for the breathing reserve and to look if it is low or normal. So as summarized in these tables, it's very helpful table, old from the since 2003, that summarize the features of every pattern. For example, in the cardiac limitation, we'll have, if we start from the bottom line, so the peak VO2 will be low abnormal in all limitation. And then we'll look for the ventilatory threshold. So anaerobic threshold, or we call it anaerobic threshold. So if it's present, that's abnormal, then we look for the other parameters. So if the ventilatory reserve, usually in cardiac, we'll have large ventilatory reserve because we don't have lung problems. The slope may be increased. I will start from the bottom because it's better to understand the interpretation. Then usually the cardiac patient will stop the exercise due to leg fatigue. This is also another important information. Oxygen saturation, typically in cardiac patient, will be stable. There is no decrease in saturation. And auto pulse plateau early or abnormally in cardiac patient. Dead space, it will be decreased because we don't have ventilatory limitation, or the patient have normal response of dead space. So this is the cardiac limitation. And the pulmonary will start from the bottom lines. So they will have big VO2, low big VO2, and there is anaerobic threshold. We can identify it. The ventilatory reserve will be low, as we mentioned before, and the slope will be high, more than 34. And usually the patient stop exercise due to dyspnea or leg fatigue. Oxygen saturation typically will decrease if the saturation decrease that toward the pulmonary limitation more than cardiac limitation. And the patient will have a small or absent heart rate reserve. In the ventilatory limitation, I will start from the bottom. So the peak VO2 will be low, and we cannot identify anaerobic threshold in ventilatory limitation. So it will be absent. You cannot identify it at all in the usually or typically in ventilatory limitation. The slope of V to VCO2 will be high, and the reason for stopping limitation is typically short breath. Peak CO2 will be increased or stable, and patient will desat. The other important things in the ventilatory limitation, the O2 pulse will increase throughout the exercise, which is opposite to the cardiac or pulmonary vascular limitation. And the other things that typically present in ventilatory limitation, patient will have large heart rate reserve, and the blood pressure rise throughout the exercise. So we cannot use single parameters to identify the better. We need to look for the many parameters to have a balanced approach to exactly identify the better. So we need to look for the many parameters. Then we can identify the better after we look for the many numbers. Sometimes you have like this contradict parameters, but usually we're looking for the several parameters that confirm better other than better. In this articles, it's very nice article. I recommend you to read it. It's talking about a practical aspect of cardiopulmonary exercise in children. It's published in 2023. And just I will highlight some key points from this articles. So we should make sure, as mentioned in this articles, the face mask should be, the size is small enough to fit the child face, because it's important to not have leaking with the face mask. And we can know that there is leak by very low numbers. As you can see here, if the parameters peak VO2 less than 0.25, or minute ventilation less than 9, or respiratory exchange ratio less than 0.7, that might indicate we have malfunctioning of equipment or face mask leaks. It's really important to make sure we don't have technical parameters. Other things in the children, in the CPET, we have to use the small size of blood pressure cuff to have accurate numbers. And the total duration will be same as in the adult, between 8 to 12. And the protocol will be designed based on the height of the patient. So we'll increase based on the height of the patient, the intensity of the exercise gradually. So now we'll move to the second part of the lectures, the prognosis. So in this very nice articles, published in JACC in 2016. They are discussing the importance of CPET in heart failure patients. So the risk stratification, which is mentioned in these articles for advanced heart failure, first of all, the peak VO2. It's considered as important predictor prognosis in heart failure patients in many studies. And the peak VO2 percentage of predicted peak VO2 and exercise duration had the strongest ability to predict mortality in heart failure, reduced ejection fraction. On the other hand, if the patient peak VO2 more than 14, the mortality will be low. And that reassuring us patient mortality is low, and we can optimize medical treatment for those patients and doesn't need transplantation for this patient or devices. So the peak VO2, it's predict also mortality in HFpEF patients, not only heart failure with reduced ejection fraction. So it's really very important parameters in the prognosis of the patient. Also, we can identify the patient need for the transplantation. So they mentioned if the peak VO2 less than 14, that means patient might need, and it showed poor prognosis, and we should consider transplantation or ventricular assist device. But we need to make sure patient not in beta blockers. If the patient in beta blockers, we should lower our threshold to less than 12. And we should also consider the variation due to the high or low BMI. And in those cases, we should consider less than 50% as indicate poor prognosis. So also they mentioned in these articles very important parameters that we can use it if the patient doesn't reach the maximum effort of the test. So if the patient doesn't reach, or we know a patient cannot do the maximum exercise, that's not mean the CPET is not helpful. It's very helpful, and I will show you many studies that confirm that by many parameters. First of all, the oxygen uptake efficiency slope, we discussed that before. In heart failure reduced ejection fraction, it's shown if less than 1.4, the oxygen uptake slope, that increase mortality 2 times. Peak VO2 at anaerobic threshold, not peak VO2 at the anaerobic threshold, not peak VO2. If it is less than 11, it's associated with 5-fold increase death at 6 months in 223 patients with heart failure reduced ejection fraction, published in 2002. Also, the steep of minute ventilation to VCO2 and exercise oscillatory ventilation are among the most potent predictor of poor outcome in heart failure patient. The presence of AOV is consistently associated with 1-year mortality more than 20%. The combination of high slope and AOV represent a particularly high risk population with 6 months, 40% heart failure hospitalization and 15% death. Also, another parameters, chronotropic incompetence and slow heart rate recovery less than 6 support poor prognosis. So we have those numbers, and as shown in this very nice diagram, as you can see here, we have red zone and green zone. The red zone is the high risk categories, and the mortality more than 20%. So we look for the many numbers that we cannot, if the patient doesn't reach the maximum exercise capacity. So they do this study in symptomatic ambulatory heart failure patient with NYHA class 2 to 4, and they look for those numbers, and they can divide our patient in 3 parts. the high-risk patient, those patients having high slope, more than 36-minute ventilation, and they have exercise oscillatory ventilation, and the blood pressure drop or less than 120, and patient has chronic incompetence or slow heart recovery less than 6, oxygen uptake efficiency slope less than 1.4, VO2 at an anaerobic threshold less than 9, and peak VO2 less than 14 without beta blockers, and less than 12 with beta blockers. If the patient have those numbers or most of these numbers, that means the patient is high risk and mortality very high, and we should consider advanced heart failure treatment, either transplant or LVAD. So it's very helpful to identify those patients. On the other hand, if the patient peak VO2 is more than 20 and VO2 at anaerobic threshold more than 11, and the slope is less than 30, and there is no exercise oscillatory ventilation, it's considered as low risk and more than 95% event-free survival at 1 year. So it's very important to categorize our patients, and very helpful tools to identify the high risk and opposite to low risk patients. Also, this very nice articles, I recommend you to read it also, regarding the CPET in pulmonary arterial hypertension. I will just show you some key points of these articles. So, of course, the right heart catheterization remains the gold standard to confirm a diagnosis of pulmonary arterial hypertension. But the beauty of CPET, it is safe test even in patients with severe exercise limitation. The other things that advantage for CPET, the pulmonary hypertension is considered as a progressive disease. And the right heart cath is invasive procedure. We cannot do it frequently as the CPET. So we can use the CPET for those patients regularly to identify the severity of the pulmonary hypertension. So as mentioned in these articles, the CPET parameters can predict or sometimes confirm the vascular disease better, but that cannot confirm a diagnosis or of pulmonary artery hypertension accurately. So we need to confirm it by the right heart cath, but can give us very important information that suggests very likely patient has pulmonary arterial hypertension, especially the slope. If it is more than, it's very high, steeper of ventilation to VCO2. Also, they mentioned that if the beat CO2 at the anaerobic threshold less than 30, this is suggestive of pulmonary arterial hypertension. And if it is less than 20, the likelihood of pulmonary hypertension is even higher. Because these values are unusual in other clinical conditions. So in conclusion of the lectures, CPET is a safe test even in patients with severe exercise limitation, and it's unique, but unfortunately still underutilized and unrecognized. It's very helpful to identify factors contributing to the dyspnea and exercise limitation, and it's very important tools to generate prognosis information about our patient. And it can evaluate the impact of therapeutic intervention that we manage our patient and to follow our patient either by the surgical or percutaneous or medical management. And it's really important tools for screening for existing ischemic heart disease, peripheral artery disease, or arterial hypoxemia. The CPET is very important tools, and it's very helpful. And I recommend everyone to use it for his patient. Thank you for the listening, and I'm